So we're moving on to Breanna's case. Breanna has a child with trisomy 21. It was an unexpected finding in the delivery room. So you are her nurse. This case is going to incorporate not only content from week 2 that we just talked about with aneuploidy and week 6, where we go into more depth about chromosomal disorders, but also incorporating content from week 4, where we discuss the role of the professional nurse. Because unlike the previous cases where you were a nurse but not the nurse, now you are Breanna's nurse. Breanna is a 37-year-old woman who has given birth to her first child, a male with features characteristic of Down syndrome, otherwise known as trisomy 21. You are her postpartum nurse. She opted not to have prenatal genetic testing, although a routine ultrasound showed a thickened nuchal fold. That would be like an area of thickness at the base of the neck in the back. It's a marker for Downs, but not diagnostic. So some children have that thickened nuchal fold and they don't have Down syndrome. Other times there's a measurement error on the part of the ultrasound technician. Let me move that. The infant had decreased muscle tone at birth and cyanosis that did not respond to normal resuscitative efforts. Further testing revealed that the infant had tetralogy of Fallot. It is a cluster of 4 heart defects that is more common in infants with trisomy 21. The pediatric cardiologist is recommending surgery. You have been caring for Breanna since her C-section yesterday. She has not visited her baby in NICU. She has a flat affect. And even though she originally indicated that she wanted to breastfeed her baby, she has so far declined to pump or hand express milk in an effort to initiate lactation. She tells you about her conversations with the neonatologist and pediatric cardiologist and states that she is overwhelmed by the information. She claims that she never saw this coming. During your assessment, she states, I was 36 when I got pregnant. That's not that old. I took my vitamins. I exercised. I didn't have a single glass of wine. I swore off sushi. How did this happen? As a nurse, you want to respond with accurate information and also with sensitivity to Breanna's feelings about this experience. So what is your understanding of how the infant came to be affected with trisomy 21? Most likely. Option 1, it could have been caused by environmental exposure to teratogens. Option 2, there may be a family history of the condition. Option 3, it was probably inherited from the paternal Y chromosome. Or option 4, it is caused by a mistake in duplication of chromosome 21, duplication and or division, and is more common in mothers as oocytes age. Correct option was 4. Trisomies are most commonly caused by an error in duplication and division of genetic material during meiosis in the sex cell, in the ovum. They are associated with increasing maternal age because ova are developed during fetal life in the biological female. The development of ova are paused in the prophase of meiosis 1. This is a whole lot of biology here. But we have all your eggs are already there by the time you're born. They've been there for months. The quality of those cells, by the time the woman is of age where she can ovulate, kind of, stays normal for a while. But as she ages and gets past the age of 35, the quality of the egg starts to deteriorate. So now we have to go through the rest of meiosis 1 and meiosis 2, and there can be mistakes in the duplication and or division of chromosomes. That explains the increased risk for miscarriages as women get older because most trisomies and monosomies are incompatible with life. At some point, the instructions just don't make enough sense to that growing embryo to continue developing into a human. Interestingly, there are more children with trisomy 21 born to women under the age of 35 because that age group has more children overall, but the percentage is lower. because you have maybe, many more children being born, the number of children is larger in younger women, but the percentage of children is higher in older women. If that sounds confusing, just, it's just a numbers game. So this scenario could have affected a 25-year-old and you would have no explanation for why this happened, other than it was a mistake that happened when your cells were dividing. That's all. That's all you really know. We do know that it happens more frequently in women over 35. That's why their miscarriage rate's higher. But there's not really anything that Breanna could have done differently to avoid having a child with a trisomy at this age. What's a therapeutic statement that best addresses Breanna's concerns? We're certainly not going to tell her, well, it's because you're older. We just now want to be sensitive to this experience that she's having. Therapeutic communication questions and nursing tests always present you with 4 options that sound like something you would never, ever say in real life, but you need to sort of get used to answering these questions and also get used to the idea of what therapeutic communication can look like. And then you can make it your own. Option 1 for this question is, it sounds like this diagnosis was unexpected. It must be very overwhelming for you. Option 2, do you think you should have had prenatal testing? Option 3, God only gives us what we can handle. You were chosen to be this child's mother. I can take you to the NICU now. Or option 4, don't worry, he's in great hands. Our pediatric cardiovascular surgeons are the best in the country. Which one really addresses Breanna's concerns the best out of those 4? Even if none of them sounds like something you would say. The correct option in this item was 1, reflecting Lisa's shock and surprise to indicate that you were listening and you understand what she's saying is the most therapeutic option. It lets her know that you're listening and you're open to hearing more. Option 2, asking Lisa if she thinks she should have had prenatal testing implies that you might be judging her for making the choice not to be tested. Never use the word should. If you see that in a test question, you can pretty much rule it out. Option 3, this is God's will and he chose you and let's go see this baby. That imposes your beliefs and your values on the patient. It's not therapeutic and it might be pushing her too hard. Maybe she's just not ready yet. Option 4 dismisses Lisa's concerns. Don't worry, he's in good hands. It doesn't really address anything she just told you. It's not therapeutic. It might be more natural, but it's not therapeutic. Later that day, the lactation consultant visits the patient. You enter the room shortly after the lactation consultant leaves and you encounter the patient hooked up to the breast pump and crying. She states, "Can I tell you something? I can't stand the idea of having a kid with a serious disability. I can't even look at kids in wheelchairs. I always look away. And I wanted to have at least 2 kids, but now I'm afraid that if I get pregnant again, the same thing will happen. What are the odds of this happening again?" Being that you're a good nurse, you give mom a box of tissues, you sit down, make eye contact, and you prepare to answer her question. What are the odds of recurrence in a subsequent pregnancy? Let's look at some options. Option 1, 50% if the father is a carrier. Option 2, no higher than for any women at the same age at the time of conception. Option 3, lower than those of a woman who has never had a pregnancy affected by trisomy 21. And option number 4, the only way to predict the odds is to test the mother's karyotype. The correct option was 2. Her odds are the same for any woman her age at the time of conception. Now, she'll be older than she was at the first pregnancy, so her risk may be slightly increased than it was, but she still has approximately 1 in 150 or 200 chance of having a child with Down syndrome. It's a new toss of the coin. The odds are not affected by paternal carrier status. There's no such thing. The paternal karyotype in this case must have been normal since the father did not have Down syndrome. He would not have been able to father a child. The karyotype, Breanna's karyotype, is not going to reveal anything useful. She's 46XX. She does not have a trisomy. So this is a disorder caused by inappropriate division of genetic material in a germ cell. rarely can be caused by the paternal chromosome. One germ cell has an extra chromosome. It can happen on a paternal haploid cell, just less likely because the cells are being created every 60 to 75 days. They haven't been preformed 37 years ago. The odds are not different because of an affected pregnancy. So it's not like the body knows that it had a child with Down syndrome and now it's going to not do that again. Every conception is a new toss of the coin. Okay, let's see. Are we on? Yep, we are done with Breanna's case study. We may see her again, but we're going to move on to Maud. It'll be a separate video.